Okay, well, I guess we'll get started. So welcome to our third webinar of the OD Prep Knowledge Exchange webinar series. Thank you so much for joining today. I'd like to begin by acknowledging that today's webinar is being broadcasted from the unceded traditional ancestral territories of the Musqueam, Squamish, and the Tsleil-Waututh Nations. All right, so before the introductions, I'd like to share a little bit about the OD Prep Knowledge Exchange series for those of you who are joining us for the first time. So as I mentioned, today's webinar is the third installment of the 7-part webinar series called Overdose Prevention and Response, Essential Practices, or as we call it, OD Prep. Brilliant name. I did not come up with it. The project is a partnership between the Community Action Initiative, Public Health Association of BC, and the Canadian Mental Health Association, the BC division. It began in early 2020, and the goals were mainly to identify unique practices in peer-led groups and community-based organizations to address overdose and poisoning prevention and response. We wanted to share these essential practices across the province, these unique responses, and collect information and innovative findings to advance policy at the systems level. So today is our webinar, Hey Pal, You Okay? Safe Washrooms and Episodic OPS. Today we will be joined by Emily Sollows from the BC Centre of Disease Control. She's going to outline the ethical and professional obligation to reduce preventable deaths caused by the toxic drug supply. Emily works to institutionalize peer witnessing, an essential practice that we now call Episodic Overdose Prevention Service, or EOPS. EOPS is a service or intervention that healthcare and social service providers can offer on an as-needed basis in anytime, anywhere overdoses may and can occur. We will also be joined by Shannon Riley from VCH and Kali-olt Sedgemore from the Coalition of Peers Dismantling the Drug War. They have been presenting together on the topic of saving lives, safer washrooms, and together they will shed light on the desperate need for safer public washrooms, misconceptions about drug use in public washrooms, and offer a checklist to implement safety changes in the workplace or community spaces. Both the general public and service providers can help and make these spaces safer for everyone and keep community members safe while decreasing the burden on washroom management. So some introductions. My name is Jane Kiyosaki. I'm the Municipal Harm Reduction Coordinator from Community Action Initiative, and I'm joined today by my colleague, Tanis. Tanis, would you like to introduce yourself?
Hi, everybody. My name is Tanis Rose Oldenberger, and I was born, raised, and continue to gratefully live, work, and play as an uninvited guest on the traditional, unceded territory and spiritual realm of the Sollows Coast Salish people. I have over 15 years of experience and expertise as someone who lives with a concurrent mental health and substance use disorders. My lived experience journey has taken me through many years of severe alcohol, cocaine, and opioid use, sex work and drug trafficking, through the criminal justice system via incarceration, courtrooms, and probation officers, to an authentic version of recovery that includes many layers of harm reduction, including tested drugs from a trusted source, peer support, self-care, cannabis, and other psychedelic plant medicines. Gifts of my recovery today look like healthy relationships, getting my license in a car again, celebrating 1 year since I last left my check-in at the Community Corrections Probation Office, and also 1 year living in the same beautiful basement suite. At the end of the day, I aim to treat myself and those around me with acceptance, love, and respect. I've also had some amazing opportunities for growth in my career. I've worked with various organizations, including BCCSU and Rain City Housing. I'm currently active in the Provincial Peer Network, and I'm working with a local group to bring peer-led mobile harm reduction services to the Upper Fraser Valley. I have most recently worked with Community Action Initiative, interviewing and collecting data from the CAT teams across the province. From that project, I was asked to join CMHA and PHABC on this OD PrEP project, interviewing more amazing organizations and groups across the province. These webinars are here to encourage connections amongst our incredible network of lived experience experts, and I'm honored to be a part of these conversations. That's what today's webinar is meant to be, conversational. So please ask your questions as they arrive for you during the presentation, and we will try to answer as many as possible as they fit into the discussion. I feel that the topic of this webinar is very important, especially in the wake of this year's International Overdose Awareness Day. This day highlights for me the sheer number of loved ones that we have collectively lost to overdose. All overdoses are preventable, so I hope you learned something new today, find a new resource to take away, or most importantly, if you have yet to find yourself responding to an overdose emergency, I hope that you leave here feeling empowered and confident to do so. Thanks, Jane.
Thank you, Tanis. So we will be your host for the next 90 minutes or so. And to start off, I'd like to point out a few features of GoToWebinar and a quick rundown of the agenda. So as you kind of get yourself sorted and organized on this GoToWebinar platform, there are two options for sound. You can listen with your computer audio or dial in by telephone if you'd like. If you're finding you're having difficulties with one audio option, you can always just switch to the other at any point and it'll just automatically let you back in. Or you're welcome to use a landline if you're using that telephone option, or turn off that output on your computer's speakers to prevent the awful feedback noise. We are going to be recording today's session and posting the video online at caibc.ca. So more information will come about after the webinar. And the PowerPoint slides and all the resources that your heart desires will be made accessible and downloadable as well. There are several resources from our presenters that you can download immediately in the handout section of the control panel on the right-hand side of your dashboard there. The format of this webinar is going to be kind of this live Q&A session. We want to hear from you, of course, as Tanis mentioned. So following the introductory presentations, we'll begin the discussion by prompting a couple of discussion questions using the poll feature. And we encourage you to join us by participating in these multiple choice polls, dropping any additional answers in the chat box, and any comments you may have at all. You can type your questions in there and responses into the question section of the panel. And if you'd like to address your question to a specific panelist, just make a note of who you are addressing it to. And we'll do our best to incorporate relevant feedback from the audience into the discussion. All right, let's hear from our presenters. So Shannon, give me first. Over to you.
All right. Good afternoon, everyone. I'm honored to be here today doing this presentation with Kali and Emily. My name is Shannon Riley, and I have been nursing in the community for over 20 years. Many of these years I spent in San Francisco, and many of them here in Vancouver on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. I've been in my current role as a nurse educator since BC declared the overdose emergency in 2016. The focus of my work is educational support for overdose prevention sites, housing, and washrooms. Today, I'm here to speak with you about washrooms and safe or safer spaces. Why is this topic important to me? Well, I spent 10 years working in a drop-in center in San Francisco and saw many firsthand overdoses where people who are marginally housed or homeless needed to take care of themselves in the washroom spaces. As a result, people who were using substances were using alone. So I responded to many overdoses in this space and had a chance to do some problem solving around how to make this space safer. Because the policy in the States and current policy did not allow for us to do anything else. During this time, I also had a friend die in a washroom. So this is why I'm here today. Holly and I have had a chance to present on this topic of safer washrooms for any facility that provides this service numerous times. But adding in this additional safer spaces feature of episodic overdose prevention sites with Emily has really added to the way that I envision the work we are doing. I used to envision these two strategies as separate strategies, and now I realize that they need to coexist, especially for healthcare settings that don't have a permanent space for people to use substances. So my first slide here, why is washroom safety important for all people? And, really, I just wanted to point out that, it's people need privacy in their days. And as I mentioned already, this space is often the only private space that some people have for self-care. And anyone can have a medical emergency in this space. Next slide. So this is a slide many of you have seen, and I just really want to point out that, we have this current spike, and it really is because of COVID and the things that have happened since COVID. So what has happened is we've had closure of drop-ins. The Eops, or the overdose prevention sites, for those of you who don't know what this is, they are supervised consumption spaces that first began opening in November 2016 after BC declared the overdose emergency. And then to tag along with that, an Eops is an episodic overdose prevention site. So basically a space that is maybe temporarily used as a space for people to consume drugs. And Emily will really get into that more. So overdose prevention sites had limited spaces. There was closure of businesses, decreased access for basic needs, water, so water and food and places to sleep, increases in using alone, no guest policies, people isolating from others, increased toxicity of drug supply, the list goes on. So that's really just what I wanted to emphasize with this slide. Next slide. So how do you know if people or substance use is happening in your washrooms? And I think we all have, some ideas, but just a quick list here too is, supplies are left behind, clogged toilets and with supplies, blood on the, on the walls or the backs of doors, smoke, or smell of matches, incident reports, asking people, and ultimately overdose incident fatalities. And there's a document here that's shared in Google Doc that is research that came out of Victoria in 2016 that says all washrooms are de facto consumption rooms. So you can take a look at that. Next slide. These are some quick, easy wins from our checklist that VCH made on safer washrooms, on ideas that we compiled from many organizations that do this work in the community. And I will get into this list in detail during our question period. Next slide.
Rebecca speaking.
And then this is a picture of one side of our checklist. And I just wanted to show this to you so that you could see that there's basically some minimal costs and minimal effort, and then medium costs and medium effort, and then maximum costs and maximum effort. We've broken it down this way to help people implement things easier at their sites. Next slide. And so one of the things that we can consider when we're talking about technology, and again, I'll bring this up later, but, if we want to know when people are using or when they're at risk in a washroom, it usually has to do with a lack of motion. And then how do we want to be notified as staff? Do we want that to be a sound? Do we want that to be a light? Or do we want that to be a text message? How are the ways that we want to get this information? Next slide. And for those of you who have worked in settings that have public washrooms, you may have seen sharps containers vandalized, or because people need to get items from them. So just creating the most secure system possible so that people can put their sharps or their substance use debris in here, and it doesn't end up in the toilet, and it doesn't become a risk for another vulnerable person accessing those used supplies. So here's just a couple pictures that have changed through the years from ECS cares that show some different versions of some more secure sharps containers. Next slide. So here's these next two slides are just examples of signs that I really like from AIDS Vancouver Island as far as language goes. So if you're considering, putting out signs or communicating your safety plan to people, just to use kind language, even if drug use is not allowed in your washrooms, and just provide basic information for people so that they can keep themselves safe. Next slide. I like the way this one ends specifically, right? Talk to staff for more info and stay safe. Next slide. So we have a picture, another big data slide here, and I really just want to show this because we can see that washroom fatalities have decreased during COVID, and the decreases because there just hasn't been access to washrooms. That's that's largely the factor. But that doesn't mean that people aren't dying. And you can see that, private residents and other numbers there are increasing. So we're basically just diverting where people are using alone instead of a place, instead of a facility where there are quicker access for people to respond. And then my last slide for my introduction. The number one goal for emergencies is reducing response time. And that is how we focused our work before talking about Eops. This is still really important, just like what we talk about in this slide, like how to call 911. What are the important things to share with EHS? Like the big takeaway I have from preparing this presentation is that safer washrooms combined with Eops helps us to have less emergencies when done well. But emergencies are handled better when there are more preparedness tools, and your staff know the protocol for overdose response safety at your site, and really just how to call 911 if that is the role of your frontline workers. So I'm going to leave you with that, and I'll pass it on to Kali.
Thank you so much, Shannon. So we're actually just going to pass it on to Emily and then Kali after that.
Thanks, Shannon and Jane. Hi, everyone. I can't see anybody, and I'm just staring at a screen of myself, so bear with me. My name is Emily Sollows. I work as a nurse educator with the Bccdc Harm Reduction Services, and most of you know that program as Toward the Heart. Here talking a little bit about episodic witnessing, as kind of one of the things I've been working with the regional health authorities to enhance services for folks actively using substances, and to really prevent more deaths, because we still need all hands on deck. Next slide. This is an image of a public-facing resource that we created to let folks know just a bit more about the Episodic Overdose Prevention Services, and it's the being in the presence of an illicit substance for Eops purposes for health and social service providers is that we're protected under the Ministerial Order M488 that came out in April of 2016, I believe, by the health minister, and so that acts as an exemption from the CDSA, the Controlled Drugs and Substances Act, and so there is protection that way for health and social service providers, and in here we've really in this resource really tried to make it clear that it's episodic witnessing within clinical services or clinical settings is going to be a slow process as we enhance and encourage people to practice kind of within their full scope, and especially as nurses learn what's within full scope when it comes to episodic witnessing. And so you can go and check out this resource as neat. You can go check out this resource. Next slide. Just wanting to also acknowledge and that the knowledge that we have and that we come with today really comes off the backs of people with lived and living experiences, and especially like much of the research that has come out over the past few years. While some folks have gotten a lot of like social status or made quite a bit of money getting more research, just wanting to acknowledge that it's the folks who are most impacted by this overdose crisis who are the real knowledge keepers, and just wanting to really hold space for that. Next slide. And this is just a little bit about me as we go in this conversation, and just taking care of one another while we have these conversations, and just wanting to share some of my assumptions and also my beliefs. And so I do believe that teaching and learning can be simultaneous. So I'm actually really excited to be here. And I think that it also speaks to some of what Shannon was saying related to safer washrooms and episodic witnessing, and how they can really be synergistic. And also, I may say something you don't agree with, and that's okay. And I really hope that that doesn't take away from the true essence of this presentation, of really just wanting to encourage folks to do everything that they can to stop more deaths. And then something around saying like what I think is helpful can also be harmful, and so just taking the time to understand that it can be like a double-edged sword related to, you think you can be helping but you can also be harming. And then the last one is that I do believe that health and social service providers have an ethical responsibility and a duty to care, and it is by entering the workforce as a health and social service provider, there is the assumption that we are willing to take on some risk related to supporting people's wellness in the way that they need. Next slide. So the Bccdc, actually, it's through the COVID work, but they just recently released a resource or document guide related to duty to care for healthcare workers, and just wanting to highlight that, you know, healthcare workers are bound by an ethic of care, that clients' well-being should be primary, and it's the obligation to provide the safe, competent, compassionate, equitable, and ethical care to those who depend on specific skills and training. And so just wanting to reinforce that, you know, it's part of the work. Next slide. And the Harm Reduction Nurses Association and the Canadian Nurses, if you haven't heard of the Harm Reduction Nurses Association, I would encourage you to hop over and check out their website. They've got a plethora of resources and statements that really support harm reduction as a nursing practice, and they say, so in spite of growing evidence of public health approaches, drug policy continues to be underpinned by a prohibitionist and moral stance, and it's makes it really difficult to practice within full scope when there's like such confusion between like what is an evidence-informed approach and what's a prohibitive approach, or like a moral or ideological approach. And my hope out of this is that people get a little bit more clarity in terms of knowing that as a health and social service provider, that our role really isn't there to be enforcement, and that like we need more people offering episodic witnessing to be able to offer more places for people to use that is even outside of a fixed site, and on an as needed basis. Next slide. And we'll get into this a little bit later, but the Canadian Nurses Association really kind of clearly defines, so the competing discourse in especially in public health work related to substance use and harm reduction is the Controlled Drugs and Substances Act through enforcement, and then the Health Professions Act that health providers are bound to in their duty to care and ethics, and so when there's with these competing discourses, it creates a lot of moral dilemmas and moral distress, and people aren't necessarily equipped with the tools needed to make ethical decisions to really support folks. Next slide. And then harm reduction emphasizes the importance of providing safe and competent care that's based on evidence instead of personal beliefs, ideologies, or misconceptions. And again, this is just to kind of reiterate that, you know, sometimes it feels like it doesn't matter how much evidence we have. You know, there's always going to be resistance, and but we really would like folks to stand in the power of harm reduction and supporting folks. And next slide. And then we'll get to this in a little bit once we get to the question period, but just some foundational ethical principles related to working within health and social service settings. And essentially at the end of the day is really just supporting, like, respecting clients' autonomy and self-determination, and really giving people more options means giving people more chances, and like we are quite limited in options for people because the main focus is on abstinence, and is like and we really need to kind of get out of that linear trajectory and expectation of people in order to be able to really meet them where they're at. And I think it's off to Kali now. Thank you.
There we go. Hey there, I'm Kali. Thank you, Shannon, Emily, and Jane, and Hannah. I'm Kali, and I'm coming from, I'm here with many hats. So I'm someone with lived experience or living experience that works with like doing consulting work and stuff on different projects. For instance, the Safer Washroom project, which is I just bring a peer perspective to it, or like a living experience perspective to how we can create washrooms safer, because washrooms are a common place where people will use drugs, and it's very common for people to overdose in them. And it's also, there's ways you can make it safer, and there's ways that you can make it better for people, especially because I do a lot of I guess we'd call them episodic overdose prevention in washrooms, because people want to use them in washrooms for certain different reasons. But yeah, and then my work comes from Coalition of Peers Dismantling the Drug War, which is a coalition that come together and just trying to fight for safe supplies. We do events like DOLF is part of us, and we do events like handing out free drugs to people that are clean and unadulterated, to make sure that people are getting a safe supply that's not contaminated with fentanyl or anything like that. And yeah, a lot of my work's done through just consulting and stuff on different projects for around the overdose, this toxic supply crisis, because it's becoming more and more hectic and stuff, and there needs to be more people to talk about, especially when it comes to youth that are using drugs, because the common thing that people don't like to talk about, or just think that enforcement will work for youth by detaining them and putting them into treatment centers and stuff, and that's not always the case, because youth use drugs for a variety of different reasons. And so yeah, and I'm excited to be here to talk about just different practices we can have for safer washrooms and episodic overdoses. Back to you.
Thanks so much, Holly. Kenneth, do you want to warm us up with some polls?
Yes. Next slide. Hi, everybody. I just want to draw everyone's attention back to this screen here. So if you haven't already found the question and the question box on the control panel to your right, there's a drop-down menu with a little arrow next to the word questions, and you can enter in a question or comment in that box and send it to us. I'm going to prompt everyone with a couple polls here. I'll give everybody about a minute each with each question. It's kind of a two-parter. So the first one I'll leave up for a minute. They're multiple choice. I'll take that one down, and then the next one will come up after that. So if you have any comments for that last box on the questions on the multiple choice, please share with us in the question box. Lots of responses for that first poll. I'm just going to post the second part of that now. Awesome. Thanks everybody for your participation. Got lots of responses here. I'll share the results for the first one. So I see a question here or a comment here about responding to an overdose in a car. Do any of our panelists have anything to say on that one?
I do, kind of.
Thanks, Kali.
I've responded to a few overdoses in cars, and it's one of the most difficult ones because it's like you don't want to break someone's window, but you kind of have to sometimes if you can't get in, like if you can't open up the doors. And it's kind of when you call 911 and stuff like that, they'll usually instruct you to try and open up the doors or bang or just have to break the window because it's life or death situation. So you just have to jump in there and try and do as much as you can. It's also really awkward trying to get someone out of the car if no one's really there to help you, and if they're a bigger person, it's harder to drag them out. So usually just putting the seat back helps.
Thanks, Kali. So we'll look at the poll results for that second poll here. Right. Tanis, do you want to start us off with our first question, fireside chat?
Sure do. Thanks, everybody. That was great. We had lots of feedback there from the polls. If everybody wants to come on and join me with your cameras now. Emily.
Sure.
So our first question today is for Emily. Where does substance use evidence, moral ideologies, and prohibition intersect? And how do we create more ethical, safer spaces?
Just a small question, right? When I first got that, I was like, I don't really know how to answer this, so I'm really happy if Kali and Shannon, you add some too. But in terms of creating more ethical, safer spaces, it's really doing more learning about equity, and really taking the time. If you're not a person with lived and living experience, then we're definitely not the experts in what folks need or what needs to be done. And so learning how to follow the lead of folks who are the experts. I think also I shared so it'll be on the online community some resources on ethical decision making, and in terms of the learning pieces, there are a number of resources out there that talk about ethical practice. And if we could pull up, Jane, that slide 26 again. And just, I think being a health and social service provider really does take a lot of, it's a lot of responsibility, and it takes quite a bit of transparency and accountability, and not only self-reflection, but like the self-reflection of thinking about reflecting on things that you might have done or didn't do after the fact, but it's also like having that on the spot reflection of as you're in it, and being able to understand the complexity of folks. And I guess it's not even about understanding more than the compassion. I listened to a podcast recently, Alok Vleeman, I believe is their last name, and it's beautiful, and it really talked about compassion over comprehension. And I think sometimes it's more about being able to really meet people where they're at, and offer the services in a way that is informed by like the ethics of health and social services. And so listed here, and then there's anyone else have anything to add?
Yeah, I have as I mentioned earlier, when I worked in the States, we were limited in our ability to act because of federal and state law. And, we have a lot of allowances here in Canada, especially in BC, with our declaration of the overdose emergency. And I may be asking for the sky on this one, but we know people are using substances in bathrooms and quiet spaces in our facilities by the evidence we have found, or because of incident reports or overdose fatalities. And we need to really be providing both, what you're talking about, Emily, the episodic overdose prevention sites or spaces, and safer washrooms. And also echoing what you said, like any new initiatives that we think will help always need to have involvement of the people the services for, otherwise things will get missed and it won't be the right service. So I guess my question is, we're not providing these safety measures for our clients in the middle of an overdose emergency. Is this healthcare? Are we doing everything we can within our legal guidelines that can help our clients survive the overdose emergency?
And I'll echo what Shannon and Emily said both. It's just like with services, to include people that are part of those services, and having outsiders provide knowledge or provide input, it's just can be misguided, because it's just people that know the services well as people that are part of those services and use those services. So it's just important to include those voices too, because if not, then what's the point of even, because providing outside voices that have never maybe stepped foot into the sites or your organization and stuff like that just doesn't work out for the best usually. But yeah, especially with because I used to work with a lot with youth, and so ethicals around that is a lot of people just want to save them, and it's not the right approach all the time, because it's more just you need to understand that youth will make their own decisions and need to be able to, instead of just forcing them into one thing. It's just not the right way to do it. It's like youth are going to use drugs no matter what. We all did. It's part of adolescents, we all take risks, and it's sometimes that risk is using drugs. So by providing proper care and harm reduction services to them would just be a lot simpler than just forcing them into treatment.
Yeah, Kali, could you actually elaborate on that just a little bit more? Just explain how youth and other vulnerable populations experience overdose prevention services differently.
So for youth, it's a lot of times when they, like, for instance, if they try to go to Insight, there's a process in order for you to enter Insight. Like, you need to show ID, you need to show that you're a drug user, so like track marks and stuff like that. And so that's not the right way to approach it, because it's just like, you're not gonna, we don't do that to anyone else. If we do it to an adult, we don't check them for track marks or anything like that, or ask for their ID. And then for an OPS site, like overdose prevention site, I've kind of helped change the narrative around that, which is just allowing you to come in and use their drugs and leave if they need to, because it's just, they need a safer space to go. And by denying them a service, you're pretty much telling them it's better off they're going to go die in an alleyway, and that you're not willing to provide that care for them. So you're pretty much just telling them their life is not worth it. So by allowing them to into spaces like this, and if you deny them a service too, they think they're denied most harm reduction places. They won't go to a needle exchange or anything like that, because they think that it's just not, they're going to be denied again. So they'll find usually dirty rigs or something to be used with. And then for like vulnerable populations, for instance, First Nations people or women or people of color and stuff, if they get stigmatized or deal with racism inside these spaces, or it's very man heavy, and it's very hard for people to access these spaces because it's just, they feel vulnerable, and just like, it's supposed to be a safe place where you're going to use drugs and you're very vulnerable when you're using drugs. So why not create an environment where you feel safe and comfortable for people? And that's why a lot of people use in washrooms or use alone, is because they don't feel comfortable in these spaces like this.
We have a question here from the audience, Canis. So it's from Karina. It's directed to Shannon. So Shannon, have any high schools implemented these guidelines that you're speaking about, specifically for youth?
Not that I am aware of. Yeah, and I don't always find out everything, right? Like, I have my ear to the ground. I'm talking about washrooms with everybody, but I actually haven't heard about a public school board or any school board that's doing any of these measures. Emily, have you heard anything? Or Kali?
I know that some schools across the province, some high schools have, because our program does the take-home Naloxone program, and I know that some schools have reached out to the program to have kits available to send home with folks if they wanted to access. So I know that that's one thing. I'm not aware of witnessing substance use. What I will say, outside of like a school setting, and just in general, what I'm learning, the more that we work to kind of institutionalize a episodic witnessing service or practice, that we're finding that places have been offering on the spot witnessing for years. You know, it's not necessarily a new thing, and I think the more we talk about it, the more that we're going to learn that there's been places who have offered this service by word of mouth. I know even now for episodic witnessing, in terms of trying to publicize, this is part of a conversation we're having, is like, how do we publicize it? If we do have, let's say, a nurse who's employed specifically to do this, and really at this point it's a word of mouth, which is limitation. So I think we're going to find out more as this becomes like a more commonly talked about, but that's like anything. So stay tuned.
One last comment. I was going to say, I definitely have heard when parents in particular say, if my child would have had access to Insight, then they wouldn't have passed away. And I don't know if that exactly is true, because Insight isn't necessarily for all people. Like what Kali was saying, it's pretty male heavy, and there isn't a lot of young people there, at least when I worked there. It really needs to be a culturally appropriate setting for a young person to feel safe using a setting like a episodic or a permanent overdose prevention site.
Well, and especially historically when, it's like when services are built on, okay, so if someone under the age of 19 comes in, then there is a potential for a report to ministry. And so when people know that that's like part of maybe policies that are in place, that people are less apt to access the service. And it also makes me think like there was attempts to amend the Mental Health Act in BC recently around if youth go to the emergency department after experiencing an overdose, then the proposed amendment to the Mental Health Act requested, Kali, interrupt me at any point, but essentially what they were trying to do was to detain youth who came in who had experienced overdose, and just like it comes back to my point of like what I think is helpful could be harmful, and we know that we also CDC put out a position statement, or it's not a position statement, an evidence summary on why detention-based services aren't effective and really actually cause more harm. And so it's those kinds of policies too that really limit people from accessing services.
Well, that in Bill 22 is just also awful because it's like you're detaining a youth for 7 to 14 days. Think about the tolerance that youth is going to have when they come out of it. Think of the overdose risks they're going to have coming out of there. They're not going to trust anyone anymore, so they're not going to go any place where it's safe to use. They're going to probably more likely use in a back alley or something like that, and it just creates a lot of different issues. And it's also just unethical to do that to a youth, especially if they're like a lot of youth use drugs to stay alive. It's a point to come across that a lot of people don't understand, but it's just some youth are using drugs to stay alive because it's only things that they have control over and stuff. So yeah, there's a lot of problems with it.
Okay, this question is for Shannon. Can you describe how someone would better advocate for installation of public washroom interventions like blue lights, motion sensors? You're on
mute.
Right, yeah, actually, Tanis, I think this is a good question for slide 10, just like some easy wins of things that people can do. While you're bringing it up, I'll say, a note on blue lighting or dim lighting. There's a lot of research out there that shows that it causes harm, and the Fraser Health has a great document that you can find online, and also will be attached with this training that shows that it not only does it target people so that they might not use in the safer space, which is the washroom. They will go outside then and be in a less safe space, say outside in an alley where there's less people around. But also it's targeting people, a collateral damage of, say, like elderly folks or people that are vision impaired, and then you have, other harms that can be caused because you're specifically targeting one group of folks. So it really is a harmful strategy. I've been in really dimly lit places too, where I'm like, I know where you're going with this. Like this, you're doing the same thing as blue lighting, but just with a different lens, right? So the other things that we can do though, like we can do signs really well. Like there's some really great signs out there. You need to have great, or like font size that is big enough for people to read. And if they're in a washroom, they need to be covered in plastic. They need to be something that people, look at and can understand that this is important. And you just need to maintain the signs. If the signs come down, and replace them. Or if you're putting a sign by the sharps container to tell people about how to get access to the overdose outreach team, like just make sure that that's always there and that's something that people can rely on. And also understand that people aren't always going to look at signs, and literacy levels are also an issue. So always be talking about your safety plans with people that are using your washrooms. Staff training, whatever you as an agency allow your staff to do, we'll only just give them extra tools so that they know how to respond. So if all they can do is call 911, then help them call 911 the best they possibly can, you know? But if they can administer naloxone, then make sure that they practice and they go through drills. If they can give breaths, like make sure they just know how to do that and they have ease with it. So what is your policy? Do they know it? Do you train to it? And with that, staff will have resiliency. And then also keys, like making sure that people have keys on their keychains. They don't have to run to the front desk and get a key. We've lost time. And do the doors swing out or do they swing in? And if they swing in, someone will fall against that door, and that will just really increase the amount of time it takes to get to that person. And it is a factor, and it hasn't changed really in most places. You'll see the door swing in all the time. It makes me angry every time I go in most public settings. But finally, the last one that just is the tricky one is, how do we know when someone's in our washroom? And I'll talk a little bit more about that with some technology, but yeah, it could be as simple as an egg timer if we don't have any money, or even the locks on the doors. If it's green, it's not occupied. If it's red, it's occupied.
And the other important thing is just having rig boxes in washrooms too. It's just like, it's not just meant for like a drug user's not going to see a rig box and think, oh, I can use drugs here. It's used for anybody that's like taking insulin or hormones or anything like that and needs somewhere to take it. So even just putting a rig box in your washroom is just an important thing too.
Absolutely. This one is related, but it's for Emily. So how do we help to ensure staff are properly cared for during episodic overdose prevention services, both emotionally and physically?
Again, no small question, right? I think, you know, when we like what Shannon on this slide here around the staff training, I think that's a big piece. And I think in terms of having all the supplies that one would need, if, you know, and to respond to an overdose, and then for like emotionally, I'm happy for Kali and Shannon to also hop on, but I think a big piece of this is it's difficult when folks are criminalized for using substances, because that creates unsafe places for folks to not only use substances, but for people to respond to people who may have overdosed. And I think, like at a systems level, in order for us to actually be able to support people responding to overdoses properly, is we actually have to change drug policy so it's not in such unsafe environments, because you know, we can go on about what people need to take care of themselves and blah 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 blah, but really it is a higher like issue of the conditions that are created through the policies that exist. And so if you're an employer, then having, you know, conditions set up that there's like supports for folks to be able to debrief, not only with the like employers, but also with peers and folks who maybe have a bit more experience, where you could talk about like kind of the interventions and how it could have gone better, some of the things that might come up, and also offering support afterwards, or, you know, if someone needs to take some time off, being able to pay people for having time off. And so less so about like a individual support and more so of like, we really need some strong systems changes in order to appropriately support people. Other thoughts?
I think it's also just like remembering that peers are often left out when it comes to like emotional stuff and doing like debriefing and stuff like that. So it's just remembering that if peers are working at your site or environment, to remember them, and just remembering that sometimes they do need time off, especially because overdoses can be traumatic, especially when you're bringing someone back to life. It's really traumatic, and people don't often understand that. But like a lot of times, the people that are paid out of, I don't know how to say this, people that are paid better kind of than peers, it's often they get the counseling and stuff like that, but we need to remember that peers need that too, not just not to be one-sided about that, but it's important to remember that people's lived experience also face traumatic experiences too, and especially with overdoses. So it's just remembering that they also need support as much as other people need support too.
Just to add onto that is just like agency policy. Like if there is a harm reduction policy in your organization, does it guide the work of the organization to implement the low cost, low barrier measures that we've talked about today? Like is leadership, supporting and implementing harm reduction policy to the extent that we can? Because that's what we need. If someone's not supporting that work, then it's not happening. And then staff, we know this, like it's more time, it's like something else that we have to do. And so this goes back to agency policy. If it is our goal to provide care to the most vulnerable folks in our community, then this needs to be accounted for as we change the services that we're offering.
Shannon, that kind of rolls into a question here from Lene. So she asks, how can companies find or fund Narcan training for staff? And is there some sort of provincial resource that they can go to?
That's an Emily question.
Can you say the question one more time?
Yeah, definitely. So this question is from Lene. How can companies find or fund Narcan training for staff?
Okay. Well, I think there's a few different ways that can happen through the provincial supply program. You have to be eligible for the program. So essentially so there's two programs that exist through our provincial program, and it's the take-home Naloxone program. And so that's like the individual kits that would be given out. And so as long as the kits are going to folks who are likely to witness or experience an overdose, then they would be eligible through the provincial program. And then there's the facility overdose response box, which is just a larger box that is mostly for nonprofit NGO organizations that respond to overdoses quite regularly. If it's for organizations such as like healthcare settings through the health authority, the health authorities would actually have to purchase the naloxone, much like they do all of the other medical supplies. And then if it's like a business wanting to have naloxone, then they can also purchase. I know that the intramuscular injection is significantly cheaper than the intranasal, but there are some even municipalities that are purchasing naloxone to have for folks. But does that answer the question a little bit?
I can add a little bit to that. I think just building capacity all over the place with train the trainer models. So if you have a big organization, making sure that you have multiple people that can train on your staff. And there are organizations that do paid for service training if you want to have train the trainer. I know Good Night Out does training. I believe Karmic might also still do training for naloxone, but it is really important to have that hands-on training more than just watching the Toward the Heart videos, which are excellent. You even get free naloxone too as a one-on-one for individuals going to any pharmacy, but you need to have practice breaking open that ampule. And to my knowledge, I don't know that a lot of pharmacists spend that time with people. So if you are in an overdose emergency and you've never opened an ampule, it might be a really scary situation for you. So I think that is a really important thing to add to training up a staff that's never done this before.
Thanks for that. So we've got a question from the audience from Terry. What are the best, most practical and basic ways to manage washrooms in a public space? If you're a staff member who is maybe inexperienced or underexperienced?
No, I think we covered some of them in that slide. But some other things to add are you know, I think just talking about technology, right? So I talked about like the egg timer, which is really basic, but we still, in a public space, we just never necessarily know when someone goes in that washroom. And so the thing that I like when I hear Brave talking about their technology is this scaffolding that is there to support you as staff that's serving a population of people. You're there to serve coffee, or you're there to like sell something. You're not there to always monitor the washroom. So to have this other feature that is helping you take care of people, you don't have time to do, right? So their technology for washrooms specifically is a timer that is set up in that washroom space, either in a single washroom or also now newly multi-filled washrooms that, based on the time that you've set as an agency, it could be 2.5 minutes, it could be 5 minutes. It probably shouldn't be longer than 5 minutes based on overdoses right now, because like they can really happen in 2 to 5 minutes. But it'll send you a text so that you know you need to go check on that washroom, and it's just something you don't have to think about. And that it's huge. I mean, it's not just software technology that we can look at. There's hardware technology also. So you can have a timer installed, a motion detector timer that has a sound alarm or a light alarm, and that's also happening in different clinic settings or different other settings. So some other things to think about, then other those quick wins, or when you look at the checklist that we have online, the VCH Safer Washroom checklist.
Sorry, thank you. Jane, do you have another question?
Yeah, so we have one more question here from Lene. This is for anyone who wants to answer. So she's wondering, what about in high-risk areas where there can be non-health care organizations like bars, clubs? People might frequently use various types of drugs. Where can they access drug testing supplies?
From any harm reduction kiosk, or in Vancouver anyways, they can get test strips from any harm reduction kiosk or anywhere that offers harm reduction supplies, like especially like Karmavic and stuff like that also offer them. And then same with outreach teams have them. And I don't know if there's a team that walks down on Granville Street that hands out some supplies, but I don't know if they do it at night, and it's for like after clubs and bars and stuff like that, and to like help people that are drunk or incapacitated. But I don't know if they hand out anything. But yeah, you can pick them up any harm reduction places anywhere in Vancouver anyways, and then 888 Hastings for FTR testing. And then I can't remember where the last one is. But yeah, for drug testing strips, they can pick them up at those places.
Yeah, and I think like outside of Vancouver, it really is dependent on whether there's access to testing strips or to the FTR or the FTIR machines. So it really varies. I think to get on the spot testing is probably a little bit harder than I think for get your drugs tested. You can mail it in, which I know some folks are doing, which Shannon and Kali maybe I'm a little bit more on that, but I know that that's one where folks, if you are okay with waiting, then you can send it. But I know that there are efforts to enhance drug checking across the province. And there was recently a provincial exemption for drug checking purposes for like from the Controlled Drugs and Substances Act. So historically, drug checking, like say if someone had an unusual overdose presentation, in order to get those drugs tested, you would have to go through enforcement to transport the drugs, like the leftover substance, from one place to the other. And now the Ministry of Health has pursued an exemption, so you no longer require enforcement to transport the drugs for drug checking in that same way, and so there's more and more protection for people. So hopefully with that change, we'll be able to see more testing available across the province.
Do any of you guys know where an OPS who still doesn't have access to drug testing strips might be able to find them and order them in?
Yeah, just write overdosecommunity.ca if they are in the Vancouver Coastal Health region. I mean, the hope is that all overdose prevention sites have both the benzo testing and the fentanyl testing to do on site. And then also overdose prevention sites can also now hand out the take-home fentanyl test strips. So still just only available at the overdose prevention sites for pickup. And then lastly to the Good Night Out team, that's who's walking the Granville Strip. If people want to know more about them, and they also travel and do trainings on any number of topics around safer nightlife and safer drug use.
We have a question here. Oh, sorry, go ahead, Emily.
Yeah, I'll just add a little bit onto that for outside of Vancouver. I know that there are different like peer-led groups across the province who access the testing strips through their local harm reduction coordinators. And the best way that you could find out who is for your region, if you order harm reduction supplies through the Provincial program, on the order form on the back, there's a list of who the regional harm reduction coordinators are. And I would recommend, like if you're in Northern Health, then emailing the folks who are Northern if you're looking for test strips, or if you want to distribute them or that kind of thing, and they would be able to help you troubleshoot how to get it. Because a lot of times it's if there's like some money left over, then they can kind of bulk purchase and then distribute as folks need. And so yes, so I will put the link to the supply order form in for to be shared, and then you can see who your harm reduction coordinator is in your region.
Thanks, Emily. I think that actually answers James's question, who asked, can you speak a little bit more about the mail-in drug checking service? I work in Northern BC and our community does not currently offer any local drug checking, not even fentanyl testing strips.
Jesus. The mail-in drug checking it's 880 Hastings. I can put that address in the chat. But it's
the website, the website too, Colony, the Get Your Drugs Tested website. Yeah.
That's awesome. So the next question here from the chat is, can you get intranasal naloxone through mail-in programs, or do you contact Bccdc? Who would qualify for that?
Nasal naloxone is only available for people that are you can get it if you're First Nation status, you can get it for free. But I don't know how else to access it. Here's my thing about nasal naloxone though, is I have a really big point about this, is that nasal naloxone 10 times stronger than intramuscular naloxone. So most times you're putting someone into withdrawal as soon as you're administering it. Like, yes, it does save someone, but at that same time, it's also, you're gonna be putting someone into, like, I know it's saving someone, but it's, if you're putting someone in withdrawal, which maybe they haven't been in withdrawal before in a long time, so it's like you have to be kind of cautious of that. But also people are also double dosing on the nasal naloxone, which is a lot. It's 8 milligrams, and that's 20 times stronger than intramuscular, and that's a lot for someone, especially if they and so I just kind of wear caution. Like, I know people are uncomfortable with needles and stuff like that, but it's like, I don't know, I just give caution to nasal naloxone. But yeah, nasal naloxone is available through your pharmacy too. I think you can purchase it through your pharmacy, but it's quite expensive.
Yeah, nasal naloxone isn't available through the Provincial program only because we just wouldn't be able to afford it. And what Kali was saying related to the high dose is like one of the goals for the considerations for giving naloxone is not to precipitate any withdrawal symptoms, and particularly because what can happen is people can get vomit, and in terms of like responding to an overdose, one of the main interventions is to maintain the airway. And so if someone is unconscious and then starts vomiting, like that can further complicate the response. And so giving as little as you can in order to reverse the overdose is what's kind of clinically recommended. And yeah, like Kali was saying, that it's a much higher dose, and when we look at how it works, like I think the word is like the pharmacokinetics of how it works in your body, comparatively to intramuscular, it peaks at the same rate, so it'll start working at the same rate, intramuscular and intranasal, but intranasal will actually stay in the body for a lot longer, so the withdrawal symptoms can last longer than the intramuscular, and so that means that someone could be in withdrawal for longer than what you would see maybe with the intramuscular. And so that's another reason why it's not like a primary choice through the Provincial program. And on the overdose community, or not the overdose community, sorry, the OD prep online community, there's actually a toolkit put together by, there was a giant group of people who got a whole bunch of expertise from and created a responding to opioid overdoses toolkit. And in there, it actually, there's a whole section that describes like how long it takes different routes of naloxone to take effect, and then how long that it'll stay in your system. And so again, back to the point of like preparing people and supporting people is like, I think if you have folks look at and read this document, and then that there's a lot of information in there in terms of the complexities of responding to overdoses. So I'll stop ranting now.
Thank you so much. I do have a comment here from Courtney, and if you're looking for nasal naloxone for a First Nations community, First Nations Health Authority will support through harm reduction coordinators for the nation to access nasal naloxone.
Mm-hmm.
All right, do we have any more last minute questions from the audience or comments?
I have one more here, Tanis. So the question is, what system change would you need to see to have EOPS and safer washrooms across the province? For anyone who wants to answer.
You know,
Another
I think
small
some of
question.
it has to happen within organizations, like within each health authority, or within, you know, I've had some talks with some chain cafe restaurants that have been really into some of these ideas, and they implement a couple things here and there, but it really takes leadership from any of an individual organization to start this going. And you know, we can be squeaky wheels within our organization, and we can put up checklists and things, but it really does require someone to say, like, this is what we stand for, and this is what we need to do.
Yeah, and I think, Shannon, what you said earlier about like a harm reduction policy in place is something that's really quite helpful to have. And as we've been having conversations across the province and more like clinical settings, even hospitals related to episodic witnessing, it really does require a harm reduction policy to be in place, and then also a revision of the policies that would maybe contradict that, particularly like, especially if it's written into, you know, a weapons policy that, you know, needles may be considered a weapon, and then that would lead to seizure of the harm reduction supplies. And so it again is like, it really requires some foundational policies in place to protect staff and to wrap around the work that people are already doing. Like, it would be helpful if policies could catch up in that way.
I think another thing on top of that around policies is the fact that like I do a lot of episodic witnessing with youth and a lot of episodic witnessing with women, and it's a lot of policies are like a man and a woman, or a man and a woman can't be in the same place together, like in a washroom alone together. But it's like if someone's comfortable enough with that person, you build trust with that person, they should be allowed to do that. Because it's just like I know, and especially with youth too, because it's like a youth is comfortable with one person usually, and that person is what they're comfortable with. And yes, there's a lot of issues with them being alone in the washroom, but it's like we're also going to use. It's like we can't use out in the open because everyone's going to get triggered or something like that. So it's like implementing policies that work out, but it's just like it's about building trust with that around different people too, and it's just how much trust someone has with someone is very important, and try not to break that trust with that person is very critical to creating safer places too.
You know, to piggyback off of that call, there's some research that came out of Winnipeg, like interviewing people that use washrooms and what they need to have safer washrooms, and it is allowing two people to go into washrooms together because people need help, and then also not using alone. So this is something that we need to look at organizationally. And also just some things too that we know actually cause harm. Like I've thought about this on a municipal level. Like, is there a way that municipalities can say like you can't use blue lights in your bathrooms? And it's a tricky one, and I don't have the answer for that. But these are things that we can think about. There's some other gray areas though. Like, can we mandate a certain like watt for the lights? I don't think so. Or can we say that your temperature has to be a certain degree in your washrooms? Because I've heard of people blasting really cold air in some of their washrooms so that they're not made for humans, basically. They don't want you there. So there's some of the things that they'll do to try to make you leave. So those things I don't think we can mandate in a large scale, but we do have a lot of research around blue light. So why are there still places that do this thing that is anti-human?
Yeah, that's so interesting, Shannon. And even you and I came up with yesterday, just in conversation, some building code stuff. So there's some work to be done, and some people to lobby with some of these ideas with the door swing specifically. Yeah, and super interesting when it comes to two people of different sexes entering a washroom, and you also get hassled. So then you're using faster and you could make a mistake. And so people are outside banging on the door, and right? It's not safe.
No, and also with someone banging on the door too could be like it makes someone, it could either shock someone until you end up like bucking up your arm really bad, not bucking up your arm, messing up your shot really badly, so you end up pulling it really hard and you get a big marks, and then you come into the bathroom, you're bleeding everywhere, and it's just like, oh god, another medical emergency. So it's just can create a lot of problems. And it's like if someone's comfortable enough to go into the washroom with someone else, it's like just let them.
Also, people go in the washroom together all the time. So
right?
How is it any different?
Yeah, and another thing around, another thing that's about episodic witnessing too is just like places where people don't expect people to use, and a big one is just like parking lots. It's like a big one, and a lot of times you'll like go into a parking garage, for instance, and then you'll go like won't see anybody, but then you'll move your car, then you'll see there's someone there, and it's just like we need to remember that people are using in very discreet places too, like in parking garages or behind dumpsters and stuff. So just check it before you push it back, or like check your vehicle before you pull out.
Yeah, thanks, Kali, for touching back on those questions from the polls. Do we have anything else, Jane, before we're going to wrap up?
Don't see anything else in the chat. So
I have a couple more things just to say on technology that I just want to make sure that people hear. And that was just, I had a couple of examples, and that one was a clinic in Ottawa that really set an amazing example a few years ago. And that was they have a supervised consumption space, and they knew that they still needed to do safer washroom strategy. So they have both. And people use in their supervised consumption space, and they use in their washrooms. And when they use in their washrooms, staff finds out about it because they have a motion detector system, they have a hardware system, and then people don't die at their facility. Like, it's awesome. And then, just back to the Brave technology, I just wanted to say, as far as locally in Vancouver, some places that have this technology are the Reach Clinic, the John Howard Drop-In, and Watari. And then obviously contact Brave if you want to have more information, because they have other overdose prevention technology that we're using provincially and also beyond Canada. So there is a lot of really exciting things coming from that group.
Emily, Kali, is there anything else you want to add before we say goodbye?
I think one big thing is just like, I'm going to jump back to youth again, but it's just like we need to understand that youth are using drugs, and just the fact that they're using drugs, we can create a safe environment for them by providing harm reduction education and services. And it's just, we need to understand that by trying to deny youth service to harm reduction or anything like that is denying them their life. So just remembering that youth use drugs, and remembering that youth need safe places to go to. So keep that in mind, I guess.
Yeah, and the only last thing that I would say is, like, for the kind of you know, data or stats that we have from overdose prevention settings and supervised consumption settings, is that when people have someone there to respond, we don't lose any more people, and we know that through COVID, that the collective can band together to well, for the most part, we won't go there, but the collective can work together to prevent more deaths, and all overdose deaths are preventable, and until we can get some drug policy changes, like, we really need to support folks using drugs much better, and stop treating them as if they're not human. Yeah.
Excellent last words, everyone. Thanks so much. Everybody did a great job. And I'll invite Jane to come back and give her closing remarks and say thank you to everyone.
I think you're on mute, Jane.
We all have to do it once, right? So just want to thank everyone, of course, for being here. But before I go into a big thank you, I wanted to kind of highlight our OD prep learning community. So Emily, you mentioned this, that these documents and toolkits, kind of like how long Naloxone takes to react, things like that. Any resources from any of the webinars that you've either attended or going to be attending are all on this OD prep learning community. We had a number of projects that we wanted to showcase these promising practices related to overdose and drug poisoning prevention and response from across the province, but not all the groups were able to kind of host in this webinar series. So this network of compassionate and caring individuals, peer groups, organizations, the idea is to amplify these voices and really push for change to how our province and the public kind of respond to these overdoses. So the online community is hosted on the Community Action Initiative social media platform, mobilize.io. It links together these groups and organizations working towards overdose and drug poisoning response. So in terms of our next webinar series, it's going to be Radical Pragmatism. So this Radical Pragmatism, the majority of safe injection sites, you know, that have opened to combat the ongoing overdose and drug poisoning epidemic, kind of exists solely for overdose response. And we're going to be highlighting and showcasing and hearing from New Fountain Shelter, run by the PHS Community Services Society. And they have worked very hard to create a community space that prioritizes social engagement of drug use and employed staff capable and competent of overdose response, with the ultimate goal of normalizing drug use. So we're going to be hearing from them in the next webinar. It's going to be a live walkthrough of the New Fountain Shelter, as well as followed by a Q&A. We're really excited to host them there. And just kind of want to wrap up by saying thank you so much to the panelists for sharing their expertise and kind of shedding light on all of these like really important issues, and just the intersection of Shannon highlighting, you know, the EOPS and safer washrooms and these issues that do not exist in silos, but their solutions can actually work in tandem. I thought that was really beautiful. So thank you all for attending. Thank you, Shannon. Thank you, Kali. Thank you, Tanis, for hosting, and Emily. And we hope to see you at the next webinar.